Um, Hello, everyone. My name is Dr. Shota Mrelashvili. Just my topic today, my topic is about the pseudotumor cerebri or idiopathic intracranial hypertension. Pseudotumor cerebri, also known as idiopathic intracranial hypertension, is a disorder characterized by increased intracranial pressure of unknown cause that predominantly affects obese women of childbearing age. There are a lot of just risk factors which are related to the idiopathic intracranial hypertension, such as female gender, just obese, excess vitamin A, retinol, tetracyclines, and danazol. And just some suggested that an increase in intra-abdominal pressure secondary to obesity just causes increased cardiac filling pressure, which impacts the venous return from the brain and subsequently leads to an elevated intracranial venous pressure and IIH. However, just this hypothesis is unable to just explain the presence among the non-obese population group. Also, just some studies have suggested a role of vitamin A in IIH pathogenesis based on elevated serum and CSF vitamin A, retinol, and also retinol binding protein levels reported in IIH patients. Also, although that implication of these findings remain unclear, just one theory suggests that excess retinol or retinol binding protein in the CSF interferes with CSF resorption, but a major study on vitamin A remains to be done. About the pathophysiology, to be honest, the pathophysiology remains unclear, but multiple hypotheses have been suggested, such as cerebral edema was one of the earliest, I can say that proposed pathological mechanisms for IIH. However, it was quickly criticized because the elevated ICP was not associated with altered level of alertness and cognitive impairments or focal neurologic findings typically seen with cerebral edema. Another proposed mechanisms involve stenosis of the distal portion of the transverse venous sinuses. The stenosis can result in cerebral venous hypertension and impair CSF absorption. And also it has also been proposed that there may be microthrombosis in the sagittal sinus of insufficient size to be seen on neuroimaging studies, which is blocking CSF absorption in the arachnoid granulations. However, against this theory is the absence of hydrocephalus, which is usually seen with impaired CSF absorption or overproduction. About the clinical presentation of IIH is usually non-specific. The following symptoms are among those usually reported. For example, headache, transient episodic visual loss, pulsatility tinnitus and visual disturbance, and horizontal diplopia. Okay, step by step. Headache, the most commonly reported symptom, it is usually diffuse, non-specific, and may be associated with vomiting. It may also occur with retroocular pain. Transient episodic visual loss, usually just lasting seconds, often following the changes in posture or Valsalva manners. Next, pulsatility tinnitus. It's just pull synchronous sound, classically described as a unilateral whooshing sound exacerbated with positional changes. It is considered to be specific for the diagnosis. The next, visual disturbance, typically involves the peripheral visual field with an inferonasal defect, arcuate defect also, or severe visual just constriction. Visual acuity is not usually affected and is more a sign of fulminant or advanced, I can say, that disease. And the central visual field loss may may occur in cases when concomitant just macular pathology is present. And last one, horizontal diplopia occurs among patients with associated unilateral or bilateral non-localizing 6 cranial nerve palsy. Next, diagnostic criteria by Dendy 9037. Just firstly, diagnostic criteria were established by Dendy 9037. However, over the years, some modifications were just provided, and the new criteria are now known as the modified Dendy criteria. And there's just 5 criteria: sign and symptoms of increased ICP, headaches, nausea, vomiting, papilledema, no localizing neurologic signs except for unilateral or bilateral 6 cranial nerve palsy, CSF opening pressure more than 25 cm H2O with normal CSF composition, and no evidence of hydrocephalus, mass or structural or vascular lesion, including venous sinus thrombosis on imaging, and no other cause of increased ICP identified. Okay, the diagnostic procedures. When evaluating a patient for IIH, a complete ocular examination, including a dilated fundus examination, a visual field examination, and optic nerve of just photographs is required. Subsequently, just neuroimaging also is needed to exclude secondary causes of intracranial hypertension. For example, MRI and MR venography of the brain are usually the imaging modalities of choice. Furthermore, a lumbar puncture is recommended for all patients who are just suspected of having the IIH. The diagnosis is based upon an elevated opening pressure greater than 25 cm H2O taken with a patient lying in the lateral decubitus position. And the CSF must also be studied to rule out the inflammation, that's logic, and tumor cells or just infection, such as meningitis. But patients with IIH usually have normal or a low protein level, normal glucose level, and a normal cell count. Okay, and you can see the papilledema, the right side, that one. Differential diagnosis. Differential diagnosis. Okay, intracranial mass lesion, mass effect. I can say that some tumoral lesion or something like that. Increased cerebrospinal fluid production. Look at this picture. Here is the choroid plexus papilloma, choroid plexus papilloma. It causes the mass effect that just can cause the obstruction also. In the middle one is just a subarachnoid hemorrhage. It's the typical picture of the subarachnoid hemorrhage. And what's the just pathophysiology, that how does subarachnoid hemorrhage cause the hydrocephalus and idiopathic intracranial hypertension? That once just the blood spills into the subarachnoid space, the broken erythrocytes just become trapped in arachnoid granulations, and after that it can cause here is a reduced drainage of the CSF fluid into the sinuses. That's why time to time intracranial pressure increasing, and also the patients have the hydrocephalus. Okay, next, management. So interesting one. 3 types of management: general treatment, medical therapy, and surgery. Okay, general treatment, what's that? The goal of just treatment is to alleviate symptoms of ICP and just preserve vision. Yeah. Although the diagnostic lumbar puncture may provide symptom relief, the later is often transient and requires the combination with further long-term therapy. And what is medical management? Medical therapy is usually considered among patients with mild to moderate disease. For example, among the options available, acetazolamide, it is we know that carbonic anhydrase inhibitors is believed to reduce the rate of CSF production and is the first line medical treatment for IIH. Topiramate, a weak just carbonic anhydrase inhibitor, is usually used and it's just the anti-epilepsy agent and is considered as a therapeutic option due to its efficacy and at improving headaches and allowing weight loss. We can say that it has the similar efficacy to acetazolamide for visual symptoms. And furosemide, loop diuretic, may also be of use, but it's not as effective at reducing ICP. Okay. And surgery, yes, surgical management should be the option of choice among patients with refractory headaches or more severe, rapidly progressive visual field loss when all just other options have failed to prevent progressive visual loss. Okay, and the two most used procedures are CSF diversion via shunt and optic nerve sheath fenestration. Okay, what is optic nerve sheath fenestration? It's preferred surgical procedure for just papilledema with associated severe vision loss, but no or just minimal ICP symptoms such as headache. Okay, you know that it has been shown to preserve or restore vision in 80 to 90% of patients. The procedure involves incision in the abnormally bulbous anterior dural covering of the optic nerve sheath, which just creates an outlet for continuous CSF drainage. And consequently, the CSF no longer distends the sheath and exoplasmic flow in the optic nerve is restored. What is CSF shunting? CSF shunting produces rapid reduction in ICP and is therefore most beneficial among patients with vision loss and symptoms of raised ICP. Two types are available, LP and VP. What is LP? Lumboperitoneal, and VP is just ventriculoperitoneal. Although that VP shunting is more difficult, as IIH patients don't have enlarged ventricles. It is the preferred method to its lower complication rate. And just complication of CSF shunting, including shunt obstruction, shunt migration, also intracranial hypotension, and tonsillar herniation. Next one, venous sinus stenting isn't just emerging procedure based on the findings of venous sinus stenosis in IIH patients. After just identification of the stenotic area on MRV, further testing, for example, such as just digital subtraction venography and manometry is needed to establish a pressure gradient before just proceeding with stent placement. And venous sinus stenting has been shown to decrease cerebral venous pressure, leading to increased CSF absorption and consequent decreased ICP. Just some studies have demonstrated improvement in symptoms following this procedure, but just however, despite its possible beneficial outcomes, the procedure may be associated with serious complications such as I mentioned, that subdural hemorrhage, recurrent stenosis and formation proximal to the stent. And the prognosis, so interesting one. The course of the disease is variable and may vary from weeks to years. To date, there are no prospective studies that have evaluated the natural history of the disease. Following treatment, there is usual improvement and disease stabilization. Nonetheless, many patients may not fully recover and demonstrate persistent visual field defect, disc edema, or elevated opening pressures on lumbar puncture. Permanent vision loss is the major morbidity, yes, and it's mostly related to the severity of the papilledema. And recurrence may occur just 8 to 38% of patients weeks to years following recovery from initial presentation or a prolonged period of stability. And weight gain has been associated with disease recurrence. Thank you so much. Have a nice day.